Thank you, Dr. Phuong. Thank you for your very nice introduction. Okay, good morning, ladies and gentlemen. Unfortunately, I'm the first speaker. I had to be the first speaker, but that's inevitable. So, I would like to present my topic focusing on skin-sparing mastectomy and immediate breast reduction in early breast cancer in my hospital in Vietnam. You all know that the majority of Vietnamese breast cancer patients still need mastectomy now. And so post-mastectomy breast reconstruction is necessary for many of them. And in my hospital, we use tram flap and LD flap for these patients. In this study, we have 110 breast cancer patients in early stage treated by skin-sparing mastectomy and immediate breast reconstruction from 2003 to 2006. Those patients with early breast cancer, stage 0, 1, 2, who request to be treated with breast reconstruction were recruited into the study. And those with high risk for reconstruction operation, like unhealthy patients with medical illness such as unstable diabetes or unstable hypertension, were excluded. For the technique of reconstruction, we use extended LD flap for majority of the patients. And for patients with big breast and thick abdomen fat, we use a tram flap. And patients with big breast and thin abdomen fat, we use LD flap and implant. And the NSC reconstruction was performed with local flap and tattoo afterwards. The patient was marked before the operation. And we use skin-sparing mastectomy and nipple-sparing mastectomy for the patient. The patient with the location of tumors more than 4 centimeters from the nipple, we use the nipple-sparing mastectomy and prosection of the post-nipple tissue to make sure that there's no cancer left. And this is, we have several incision selection for skin-sparing mastectomy. This is one a case of patient, and this is nipple-sparing mastectomy. Most of the patients have isolated dissection because SNAB was not performed, had not been performed in Vietnam until now. This is the specimen. The specimen was evaluated by putting into the bottle of water, and this is the LD flap harvested. The flap is transferred into the chest wall to make a new breast and to be shaped. This is the tram flap. We use the conventional pedicle tram flap. The flap is transferred into the chest wall to make a new breast, to be trimmed and to be shaped. And the nipple was reconstructed afterwards with a local flap like this. We analyzed the operative techniques and complications, the oncological outcome. The aesthetic outcome was evaluated by 3 doctors looking at the pictures of the patient after the operation and when the picture was followed up. And we used the subscale analysis introduced by Gagbe, and the outcome was classified into 4 very excellent, good, fair, poor, based on the volume, the contour, the placement, and IMF. And this is our results. We have 110 patients with a mean age of 40. Most of the patients are in the stage 2. Most of the tumor were invasive ductal carcinoma. 72% of the axillary nodes were negative. We have 67 cases with skin-sparing mastectomy and 43 cases with nipple-sparing mastectomy. This is the example of a patient with skin-sparing mastectomy and SFM incision. For a technique, we 80% of the case with extended LD flap, 16% with tram flap, and 6% with LD flap and implant. The NAC was reconstructed 3 months after the operation or after completing adjuvant treatments. This is the minor surgery. And this is the outcome of the one patient. This is time flap. And this woman with very big breast, not very big breast, but a little bit big. And with the thin fat of the abdomen, so we use the early flap implant. The blood loss is minimal. The tube was withdrawn in 5 to 10 days. And the mean volume of the specimen is 180 cc for the early flap and more than 300 for time flap and early flap plus implant. We don't have many flap complications. For the early flap, we have 13% of a seroma. And for the time flap, we have 31% with abdominal bulge. We don't have any mastectomy flap necrosis. 2 cases with NAC necrosis, partial or complete. With the median follow-up 14 months, we have 3.6% of local recurrence and 9% of metastasis. Compared with other arteries, this number is not very bad. And disease-free survival is 80% and local recurrence-free survival is 92%. With aesthetic results, the excellent and good results is more than 80%. So in conclusion, we can say that skin mastectomy and immediate breast reduction is safe with low rate of complication and local recurrence and good aesthetic result. And for Vietnamese patients, we think that extended early flap is appropriate. The majority of the patient and time flap is for women with big breast and thick abdomen fat, and early flap plus implant is for women with big breast and thin abdomen fat. This picture has been taken 3 years ago in 2009. You can see this is my mentor at the time. You can see that she's still young and more younger, but unfortunately I'm older and again more famous.
Thank you, Dr. Tran. I think that was a very nice presentation and for sharing your experience with us. I'm very pleased that you're doing very well. Perhaps I did not catch what you talked about just now. You mentioned that a median follow of 14 months.
40
months, okay. It's very impressive because it started in 2003. So for the past 8 years and with the experience, I think indeed the results are very good. You have not seen flat necrosis or not even partial flat necrosis. So what I will find out, were there any other minor issues such as hematoma or seroma collection in your series?
Yes, we don't have many hematoma, actually none of them. But because, most of the patients have a reflux, and seroma is the most common complication of this. But in this series, with the complication of seroma is a little bit high, not very high compared to other authors, high for with the other series of our series. Because after this, we improve our technique by use the quilting technique, so we can prevent seroma. Yeah.
Does anyone have questions you'd like to ask Dr. Tran? Then, okay.
Thank you so much.
Okay, we'll bring upon the second speaker.